Good morning, everybody. It is 8:30 according to my phone, and so we're going to start. My name is Lowell Tong, and it is my pleasure to introduce today's Grand Round speaker. Damien Rose was hoping to be here and to introduce Dr. Lucey, but he is on jury duty. I will just say a few words about Dr. Lucey. She and I started our UCSF careers in the 82-83 internship year, and she went on to complete internal medicine here and has had a fantastic career around the country in several medical schools in medical education, program director in internal medicine. Most recently, she was, before coming to UCSF, she was at Ohio State University, where she held a similar role and actually was dean for a while. She was recruited by then Dean Sam Hawgood, who is now our chancellor, and Dean Hawgood, Sam, made a fantastic choice in bringing Catherine in to be the second vice dean for education ever in our School of Medicine. And yes, she had big shoes to fill, but she has created her own paths, trails, scaling new heights with all of us. And I will just stop there and just welcome you to Department of Psychiatry Grand Rounds. A reminder to you and everybody that this is being live streamed and is recorded for those with access to UCSF. And we welcome you and thank you for being here.
Thank you. It's great to be here. I'm very honored to be invited to the Department of Psychiatry. You have an extraordinarily strong educational leadership in your department. I see many of the educational leaders here, it's really a great opportunity for me to get to talk to a department outside of my own home department. I'm an internist, so talking to psychiatrists gives me new insights, and so I hope there'll be plenty of time for you to give me feedback and ask questions. I'm going to talk today about trust, and I told Lowell I had a little moment of panic driving in this morning because I thought to myself, you know, probably the discipline who knows most about trust and also breaches in trust are psychiatrists, because that probably is what fills your office many days of the week, is people who have been dismayed because people that they trusted turned out to be not particularly trustworthy. I started thinking about trust last year. I was actually at a think tank that was focused on trust in the clinical environment, and then I started thinking about trust in the medical education environment, and the literature is super interesting. I'm going to try and share that with you today. But first, as you think and as you listen to me, I'd like you to just answer the following question. I'm not going to have you raise your hand, but the question is this: are you trustworthy? Are you, as an individual person, as a provider, are you trustworthy? And the reason I'm not, you're going to raise your hand. The reason I'm not going to ask people to raise their hands, because of course all of you are going to say, yes, of course I'm trustworthy. That's the coin of the realm here. And then I want to follow with a couple of different questions, and that is, how do you know? And who says you're trustworthy? Because trust is something that cannot be demanded, no matter how much we try. Trust has to be earned, and it's in the eyes of the beholder, in the eyes of the trustor. And so thinking a little bit about what it takes to be trustworthy and how we communicate trustworthiness to the people who we need to trust us is, I think, a super interesting aspect of this work that I'd like to talk about today. So those are my roles and disclaimers. I have no conflicts of interest. I am a Psych PI on a foundation-based grant for medical education. And for those of you, I forgot to say hello to San Francisco General and the VA as well. Nice to see you, or not see you, but hoping that you're paying attention. For those of you who actually might drift off in the middle of this talk, these are the conclusions. I'm going to try and spend the next 40 minutes talking about reaching these conclusions. Trust is needed in any relationship where one party is vulnerable. And the way I think about vulnerability is that someone in that relationship has something important that can be lost. Whether it's health, whether it's competence, whether it's a career, trust requires vulnerability. And it's important for us to maintain that as a critical aspect of what we do. And we often think about trust within the health professions. So a treating clinician to their patient and vice versa actually is where we think about it. But trust is absolutely essential in learning and teaching. Students, residents have much important that they feel can be lost if they don't trust the faculty who are working with them. And so as we think about this, particularly in today's environment, and I'll talk a little bit about what's eroding trust, I think, it is important that medical education take on the challenges that are in front of us, both in medical education and broader society. If we hope to educate professionals who are indeed trustworthy and can sustain trust through long-term relationships and develop trust even in short-term relationships over very brief periods of time for our patients and our communities. And the literature on trust can provide us with new insights into this important work. Well, society actually has tremendous trust collectively in the health professions. And our responsibilities to society, particularly as a public institution, is twofold. One is to build a workforce that meets the needs of our communities and our nation. So those are not only the types of individuals who come in, but the skills they have and the roles they will play in addressing the healthcare needs of our society. And secondly, and this is something we don't think enough about in medical education, but to prepare citizens who contribute to our society. And this is vitally important for physicians in their role as advocates for addressing many of the ills in society that are actually contributing to poor health and poor outcomes for our patients. And that is part of the responsibility that we have. And I think that what I found very interesting in the Governor Northam and Virginia issue was how we actually, as a medical profession, fell down on preparing citizens who were prepared to actually address many of the contemporary issues of society. So many people believe that we're in a post-trust era, and part of this is just what we hear day in and day out from social media and in the mainstream media. Science no longer rules the day. Climate deniers are totally distrustful of the scientific community. Vaccine deniers are distrustful of the medical community. Government is out of touch with its constituents, and many people don't trust politicians or the government to be able to meet the needs and actually guide them in the right direction. Politicians lie with impunity. Social media doesn't differentiate between truth from lies. And the Internet really empowers everyone to believe they know as much as experts and can transmit information very broadly and impact people who, for some reason or other, are more inclined to trust them than others. We have trust issues in medical education as well, and there are plenty of trust issues in healthcare, and we're not going to talk too much about that today except slightly tangentially. For example, residency program directors, and you're right in the middle of finishing your match list, as I suspect, they don't trust the information provided in the MSPE to accurately reflect the candidates in front of them. Undergraduate medical education deans like myself and those who construct that MSP don't trust residency program directors to use valid information in a way that's fair to the individual. Students don't trust faculty to assess them and grade them fairly, and actually faculty don't trust students to evaluate them and grade them fairly too. There's lots of concerns about bias. Everyone is nodding their heads. Trust is not something that we can take for granted in society, in healthcare, or in medical education, and it behooves us then to pay more attention to this issue. But I think there's plenty of trust to go around. The problem is that it's not that people aren't trusting. It's that they are trusting individuals who are, by lack of expertise, inherently untrustworthy. They are trusting the anti-vaccine movement. They are trusting the anti-climate movement. And why is this? People trust individuals not only because of expertise, and this is probably the number one takeaway from this talk, but because they have relationships that they feel are trustworthy. And so one of the challenges for the experts in the room in all of the areas in which you are expert is to not rely on your expertise to demand trust, but instead think about what it takes to develop those relationships. So I think the challenge for 21st century educators, whether you are in medical education, basic science education, psychology education, is to actually embrace trustworthiness as a unifying construct for learner development, so that is learning and teaching in the clinical and preclinical environment, and faculty development. That is how we prepare our faculty to be the type of educator who can actually escort our learners through a very formative phase of their lives, from layperson to professional, and imbue them with the characteristics we think are essential for trustworthy individuals. So that's our job, prepare that workforce that is full of trustworthy individuals. But in doing so, if we want to prepare trustworthy individuals, we actually have to be trustworthy for our students and our learners. Now, that statement, I think many of you may be sort of, quizzically asking, don't we do that already? That reminds me of an anecdote that Bob Wachter at the beginning of our Bridges curriculum, got invited to give a talk about the importance of systems thinking to the new medical students in the first year. He, as only Bob can do, gave a very inspiring talk about how this was going to be such a great era in medicine. We were going to deliver the highest quality care. It was going to be tremendously safe, low cost, high value, patient-centered. And instantly, all of the medical students raised their hand, and he called on one of them, and he said, well, Dr. Wachter, well, what have we been doing up until now? And if you think about this, too, if we aren't educating trustworthy physicians, what have we been doing up until now? That is not the question that I want to ask today. The question is, are we doing enough to educate trustworthy physicians and to help our physicians know what it takes to be trustworthy and pursue that for the duration of their career? Why now? Because in a world where trust seems to be under scrutiny, the professions, medicine, law, psychology, sociology, the professions have to be where society turns for reliable, trustworthy information. And so we have to guard that reputation with all that we do. And it's also true that some of the changes that are existing in healthcare are presenting unique challenges to the development of trust. Who we are challenges the development of trust. The more we are different, the more it is different to assume trust will happen just by virtue of proximity. So we are different in terms of the fact that we are very interprofessional now, and lots of different roles, people educated differently with different career goals. That may actually slow the development of trust. And increasingly diverse from a race, ethnicity, gender identity, sexual orientation perspective also presents challenges to assumption of trust. How we work may put challenges in front of trust. Technology is a really interesting thing. It used to be, in fact, that people would develop relationships and then could use technology to sustain them. Now, relationships are inverted, right? So people develop them using technology and then decide maybe to meet and develop a personal relationship. That actually changes things fundamentally, whether it's an intimate personal relationship or whether it's actually a work relationship where you might communicate only by electronic health record. And the team formation that we do is also very different and challenging for trust, right? So teams actually are much more asynchronous. Somebody takes care on Tuesday, someone on Wednesday. They're short-lived and maybe very briefly task-oriented. So all of these things are challenges. We can't use them as excuses to avoid the concept of trust. We actually have to seize them and actually move forward with that. So those of you who are trust experts in the room, just bear with me for a while, but I think it's really worth thinking a little bit about when we talk about trust, what we're really talking about. So trust has both intrinsic and instrumental value. It's intrinsic because it is the defining characteristic of the doctor-patient relationship, of all clinical relationships. It is important to the patient because it actually gives them confidence. It's important to the physician or the psychologist or the social worker because it gives their work meaning and purpose. It feels good to be trusted. It feels good to be trustworthy, and it feels bad to have someone who is cynical or skeptical about your abilities. But importantly, high trust has instrumental value because it improves outcomes. And there's literature in each of these areas. Patients who trust their provider have greater adherence, better satisfaction, and are more likely to sustain long-term relationships. Teams that have high internal trust have better performance, also individual satisfaction, and more positive attitudes not only towards their team but towards their work and institution in general. So important for those of you who are in leadership positions. The learner literature is super interesting because it is very devoid in the medical education literature. But in the K through 16 literature, so kindergarten through college, and in some of the other health professions literature, specifically nursing, there have been studies that document that learners who actually trust their faculty and have a trusting relationship with faculty have better performance, stronger motivation, a stronger sense of personal empowerment, and we'll talk about why that might be in a minute, and actually improved mental health. And so as you think about this in your roles of educating learners in the medical environment, these are all things we want for our learners. And so thinking a little bit about this void in literature, any of you who are interested in this actually might find an opportunity to pursue this intellectually. So trust is the belief by an individual that the person that they trust has the right intentions and the right ability to help them when they're in a vulnerable or risky situations. And these words that are highlighted are extremely important. Ability is present, but almost more important is right intention. So there's a concept of intention and motivation that the person who's trusting an individual believes about the trustee. And again, vulnerability or risky situations is quite clear. There are critical elements of trust. Vulnerability is an essential precursor to trust. In the absence of vulnerability, there's no need to trust. There might be trust, but there really is no need to trust unless one person is individually vulnerable. And in fact, actually, trusting relationships develop better if both sides will disclose some level of vulnerability as part of the strategy in developing trust. But trust actually has some unique characteristics that are worth thinking about. Trust, unlike satisfaction, which is a decision we make after we've engaged with someone, trust is very forward-thinking. It's actually an anticipation that something as yet undetermined but positive will happen because of my interaction with this individual. And it's that future hopefulness that I think is super interesting when we talk about the powers of trust for the patient, but also the powers of being trusted by for the physician. It's optimistic, unlike expectations. There's plenty of people who expect you're going to fail, but no one from a trusting perspective has an expectation other than optimism. It's open-ended, unlike pure task completion. Although we might say to a child, I trust you will do your homework today. But most of the time when we talk about trusting an individual, it is more global. I trust this person. I trust Lowell or Eric or Howard. But there is context associated with this, unlike traits. So trust is actually in many ways situationally in a very global perspective oriented. For example, I might trust Howard to provide me good clinical advice. I'm not sure I would trust him to actually manage my investment portfolio. So it's not something inherent in Howard. Maybe I should, but there may be things about Howard that I don't really know. If you pay attention to no slide other than this one, this is the most important slide in today's talk, and that is the antecedents to trust. I asked you at the beginning, how do you know you're trustworthy? How would someone else know, and how would they make that decision? And so there's actually a fair amount of literature. I've just given you two citations here, but there are two elements. The first is propensity to trust, right? So trust propensity, which is actually a characteristic of the trustor, the person who's going to make the decision to trust. And this is super interesting because trust propensity can be very dynamic and can be sculpted very effectively, as you all probably realize, by past experiences in trusting others. And so as we think about our roles as faculty, our need to have learners trust us is not just for us as an individual. It's for the whole faculty environment. Similarly, patients' decision to trust a physician that's positive actually impacts their ability to trust future physicians. So this is something collectively we need to do for the benefit of us and for the profession, much like hand washing. One bad hand washer can undo the work of 99% of people who wash their hands effectively when it comes to transmission of infectious agents. The second is trustworthiness, an assessment of trustworthiness by the truster of the trustee. And there are three concepts that come up in the literature and are variably described. I'll use the words that are most common: ability, integrity, and beneficence. Those come up the most in the literature. But I've actually broadened them a little bit in my own lexicon here to be the three C's: competence, character, and caring. So it's the unification of these three elements, the belief that someone has the right character, cares about the individual, and has a level of competence that's important for achieving the goals of the trustor. Deciding to trust is a deeply emotional decision. Many people would call it non-rational, not irrational, although sometimes, as I said, the climate deniers and the vaccine deniers, it seems irrational. But it's deeply emotional because what it turns out in most of the literature on trust is that the elements and decisions about an individual's character and caring far outweigh the decisions about their competence when making a decision about who to trust. And that is more true the longer the relationship goes on than even at the very beginning. Competence may actually be where a conversation about trust begins, but character and caring is where it ends for the most part. And so thinking a little bit about our work, we spend a ton of time thinking about competence, not that much time thinking about character and caring. And the consequences of the fact that it's deeply emotional are are that the violation of trust actually sparks more than just an intellectual disappointment. It sparks moral outrage or a sense of betrayal. And I think part of this is because if you feel betrayed because you trusted someone who inherently then became untrustworthy, it is as much a decision about your ability to judge as it is about their ability to perform. And so it's a violation of your own self as well as much as the individual. This idea that I thought you were someone, I thought I knew you, and I thought you were someone I could trust. And conversely, the outcome is not as important as the intent or motivation. So there are plenty of examples where people trust individuals who have poor outcomes as a result of that trust. But if they felt the trust was still maintained, often the response is forgiveness rather than anger or moral outrage. So it's really about how the relationship unfolds in the setting of it, more so than the outcomes. And that's why I think caring and character are more important than actually the competence. Now, trust in medical education is present from the very beginning. When someone decides to go to a medical school or enter into a psychology grad program, they trust that we are going to actually help them achieve their career goals. But it is critically important in the clinical environment in particular. And I want to talk about two educational viewpoints that really dominate the way we design our clinical education environment today and explain what we do in ways that are important and actually relate to the trust issue. So the first, these are two articles, one from a French group, Levay and Wenger, and one from a Russian group, Vygotsky. And they were not designed, these theories and models were not designed for medical education, but they're very relevant to workplace learning. So anytime you educate people in the setting where you are doing your work, these models are particularly helpful to you. So the first is situated learning or legitimate peripheral participation. So Levay and Wenger talk about workplace learning as a community of practice where people come together, share a goal, and work collaboratively to achieve that goal. In the clinic, in the hospital, in the basic science lab, any of these things would work. And the way learners enter these communities of practice, which are headed by experts or master, is that they come in from the edge. They enter from the edge. They've been lurking outside. Someone invites them in. And when they invite them in, they become a part of the group in an ideal workplace learning experience. And by becoming a part of a group, that means they are assigned a task that they can do that is important to the work of the group. So that's authentic, situated learning. It's situated in the community of practice, and it's an authentic experience. And it's through that work and through their attention to that work and their compliance with direction and response to feedback that they gradually move towards the expert in that, become that expert in the field. And so this is the model of situated learning and authentic, legitimate peripheral participation, which is a description of how we manage our clinical learning environments. Now, trust is important here because if I'm a student, first of all, I have to trust that you are going to allow me to come in and work with you in a fairly high-stakes environment. And then I have to trust that you as my faculty member know the type of authentic role that I am capable of doing. That is, you won't give me something that I will inherently fail at, and you particularly won't assign me a task that I will hurt someone else in trying to accomplish. Now, a parallel to that or a complement to that is Vygotsky's work. What he calls the zone of proximal development, or ZPD, is the very clever education lingo. So the zone of proximal development is what the learner can achieve with your help that they could not achieve without your help. So think about when you are, and this is actually full of trusting issues. So think about your child who is learning to swim, right? So the child can't swim without your help, right? So the zone of proximal development for a new child swimming is going to be, wearing a vest and having angel wings or whatever those things are, the swimming wings, and with mom right there, holding their stomach as they're moving along. And gradually, as that child gets better, mom steps away but leaves on the tools. Gradually, you strip away the tools. And think about the trust that's inherent in that. And if any of you had skittish kids, sometimes the zone of proximal development can last many, many years, it seems, with that. But the zone of proximal development inherently requires me to trust that you are going to move me in the direction of accomplishments that will help me move towards the center of the community of practice. So The other educational lingo I want to talk a little bit about today is a focus on competencies and entrustable professional activities, because this is the world that we live in now, right? So as we try and educate medical residents and medical students, we've decided to fulfill our societal obligation to educate the right workforce that we have to describe the work they do in terms of competencies they have. And there have been two frameworks that we have used in medical education for competency-based outcomes. One is the ACGME competencies. So these are the abbreviations for those: medical knowledge, patient care, interprofessional skills and communication, professionalism, practice-based learning and improvement, and systems-based practice. Those are the 6 ACGME competency domains. A competency domain, it's an ability that an individual has. People have been challenged by competency domains because they're not really all that intuitive. When you see somebody perform and they do a great job, it's hard to know why, which one of these domains was expert. More importantly, if they do a bad job, it's sometimes hard to sort of dissect down granularly to figure out what the problem is. And more likely, you'll find that there's problems in all of these areas, right? And so these are overlapping. They're not discrete, and they've been challenging. So Ola ten Cate, who is a professor from the University of Utrecht and actually has an appointment here because he co-directs our educational PhD program, developed a strategy or a paradigm known as the entrustable professional activities. Who's heard about that, the entrustable professional activities? So entrustable professional activities, remember I said competencies were abilities of an individual. Entrustable professional activities are descriptions of work that that individual might do. And so in order to accomplish that work, that person needs competencies. But what he did, what Ola said, is that, you know, let's tap into what faculty usually do when they make decisions in that community of practice that I talked about a minute ago. When they decide whether or not they are going to trust someone to take care of their patients, they make decisions about individual actions that they saw them take or individual work products that they saw them accomplish. And so I make a decision that I don't have to get up and go in to see a patient in the middle of the night that gets admitted to my service because I trust that resident. And so that's where the concept of entrustment comes in. What's been fascinating about this, and this is one of the things that got me started thinking about trust, is EPA's followed the competencies. So in terms of sort of the history of medical education, we spent the last probably 15 years talking about ACGME competencies, and we spent a lot of time getting our faculty used to rating our students and our faculty on these competencies. And then along comes the entrustable professional activities movement and says, well, don't worry so much about that. We're going to give you a set of entrustable professional activities that we want you to assess now. And in order to help faculty make that transition, we really undertook a greater focus on the crosswalk to the competencies. And so the greater focus on the professional activities part of the title and much less conversation about what it takes to trust and what are the elements of trust. So that raised a couple questions in my head. First off, remember I said that trust requires vulnerability. So who's vulnerable in the setting of an entrustable professional activity? As a faculty member, when I make an entrustment decision about a professional activity that I'm capable of doing, where's the vulnerability? And I would say there's two elements of vulnerability. One is personal. So I could make the wrong decision, and what I have to lose is reputation, maybe lawsuits, maybe jobs. But I think more importantly, conceptually what we are doing is we're using the faculty as a proxy for current and future patients. So the faculty is making an entrustment decision based on people who will be served by this individual today, tomorrow, and in the future. And I think, again, it's important for us to keep that in the back of our mind. Our trust decision is not just for our convenience. It's about what is happening for patients of this individual in the future. And importantly, although competencies are a critical element of that, knowing what we know about how people make trustworthy decisions, decisions about trustworthiness, particularly as we're viewing ourselves as proxies, we actually have done very little job thinking about how we would judge the character and caring of the individuals in front of us. And yet, that's critically important. So a concrete example of entrusted professional activity and how we use it is we use it an entrustment scale. And here's a typical entrustment scale. Level 1, no matter who they are and what it is, I'm not going to allow them to do anything without me, ever. Number 2, I can allow them to do that appendectomy, conduct that psychotherapy, put in a central line, but only while I'm standing right there. and it can intervene in the case of an error. Level 3 is under reactive or on-demand supervision, so I can send that medical student in to do a history and physical, and they can come out and report to me, and then I can respond if they need it. 4 is allowed to practice unsupervised, and then 5 actually could allow to supervise others in the practice of this EPA. So this is an entrustment scale. And again, I pulled this and actually reformatted it from an article on competencies. And what was fascinating is all of the examples that were given, and when you look at the EPA's documents, are really about doing. Like, what are the behaviors you would see the person do to ensure that they could get a level 3 supervision? But think about this. When you send that medical student in to do a history and physical, or the resident in to do psychotherapy, only under reactive on-demand supervision, there's a whole lot of being that you expect out of that resident. In order for you to trust them to do that, even if you're standing outside or just down the hall, there's incredible elements of their character that you need to actually have assessed to be confident that they're not going to damage that patient in the encounter. For example, prudence. You want to make sure that they're appropriately cautious, that they aren't going to do something that is capricious or arbitrary, that they have a level of fidelity, meaning that they are connected to what the patient needs, and they will work in service to those patients' needs and be faithful to the goals that are mutually important. Discernment or judgment about what happens when something goes awry, conscientiousness in getting the work done, confidentiality to the situation, of course, very critical in your work, humility, and more. There's thousands more of characterologic elements that we have to make a judgment about if we want to feel that our patient is safe under that person's guidance, even for a short period of time. And I sort of list these things just because I think it's critically important for us to ask as educators, how do we make that decision that the individual is trustworthy? So, not surprisingly, Karen Hauer, who is our Associate Dean for Competency Assessment and Professional Standards, has done some really interesting work in trying to unpack that decision to trust. And she and her colleagues did what was known as a phenomenographic study, so that's a study of phenomena, on how entrustment decisions are made. And they have found 5 critical factors, and I'll try and walk you through those. Who the supervisor is, who the trainee is, the relationship between the two of them, the task and the context in which this happens. And I just want to walk you through her model and then relate it to the model that I talked about earlier, that the importance of trustworthiness lies in ability, integrity, and beneficence, or caring, competence, and character. So it starts with a question of propensity to trust over here. So the faculty member enters with some perhaps prior knowledge of the circumstances and prior knowledge of the resident might have gotten from a feed forward. And this actually work was done through the internal medicine residency program. But the faculty member starts with a certain propensity to trust, and that propensity to trust may be related to past experiences of trust, and it may have some characterologic issues as well. You probably are wiser about that. And then they seek editing of that instinct, whether trust more, trust less, or not sure, through direct observation of the learner, comparison to a standard that's agreed upon amongst themselves and other colleagues, and they may actually seek input from stakeholders, patients, or other residents who've been working with that individual. And then they make a decision for a particular task in a context, psychotherapy in the outpatient environment, psychotherapy in the inpatient environment, whether or not to trust that individual. And that trust decision has really important outcomes. A decision to trust positively that the resident is trustworthy and can be counted upon to fulfill that task with reactive or unsupervised has really beneficial effects on the supervisor role. The supervisor can choose then to step back and direct their attention towards somebody who needs a little bit more assistance. It has more of a resident empowerment and motivation sense, and actually team functioning in a trusting environment, as we talked about earlier on, is better if all feel trusted by the supervisors and the others in the environment. And the converse is true as well. If distrust of the resident is the outcome that was decided upon by the supervisor, that role becomes more intense. Residents actually stop learning because they're not able to be trusted, and they can't actually engage in stretch assignments, and teams actually become cynical and distrustful. Now, what I really like about this model in addition to its focus on trust propensity, competency, and is actually some of the accelerators, which I think map nicely to the character and caring aspect of it. So the task has to be appropriate. Again, the resident has to trust the faculty member gave them the right task. Resident engagement and management opportunities. One of the things Karen noted in this is that sometimes the decision to trust actually is made because you watch them in a different circumstance and you make an inference. And the circumstance which seemed most relevant was leadership of the other team members. And leadership has a lot of character associated with it, right? The same elements we talked about, discernment, humility, conscientiousness, accountability, all of those things are really core to leaders, and I think she was tapping into this, although she didn't use that literature to say so. And similarly, barriers to trust were characterologic, resident red flags. Arrogance was a particular one cited, not sort of understanding the limits of their knowledge. And then, of course, there was a little bit of supervisor style as well, which may have been impacted by trust propensity issues in the past. But I want to move us away from a focus on faculty trust of learners to one of learners' trust of faculty for a few minutes, because as I alluded to at the very beginning, one of the best ways of developing a trustworthy relationship is reciprocal disclosures, what has been called reciprocal disclosures. So I trust you with something vulnerable about myself. You trust me with something vulnerable. They don't have to match ideally, but it is almost impossible to be trustworthy if you don't trust the other person. And so we have to think a little bit about mutual trust, and that's particularly important with learners. So learners are in a continuous state of vulnerability. They have a lot to lose that they think is important. They may lose the chance to pursue the career that they were interested in if they don't get the right grade or if they feel like they aren't helped. They may lose the chance to develop as much competence as possible if they aren't given feedback and encouraged to take that next stretch assignment. They certainly may lose confidence if distrust is present. And well-being, I think, is a huge issue when you don't trust the environment in which you are working, whether it's the resident or the faculty or the patients with whom you are working. They have to trust their faculty on a number of different elements that are really key to that community of practice and legitimate peripheral participation that we talked about. Trust the faculty to assign the right patient, to supervise appropriately, to assess fairly, to provide guidance and coaching, and to correct without humiliating. Because think about yourself as a vulnerable learner. If you want to ask a question, you are disclosing something of yourself that is a weakness. If you think you will be met with gratitude for the idea that you surfaced a question as opposed to chastisement for asking a question, that will change your willingness to sort of ask questions in the future. And if you can't ask or identify areas that you are uncertain about, you can't actually strengthen the part of yourself that makes you vulnerable. The consequences of distrust or betrayal of trust in the medical education environment are very substantial, as I alluded to, lack of learning. A performance rather than growth mindset. So from Carol Dweck's work, right, growth mindset requires you to sort of think that you can always get better. A performance mindset exists when you're fearful of showing that vulnerability. Burnout and cynicism, when the people who are supposed to be your role models do not appear to be trustworthy to you. A sense of moral distrust. And as I alluded to, a diminished propensity to trust in the future. So this becomes a amplification cascade where distrust and a poor trusting relationship with one faculty can actually damage future faculty relationships. So what are some elements of faculty that actually engender trustworthiness or distrust? And again, when we look at the three issues of competence, caring, and character and caring, so idiosyncratic or evidence-shunning behavior, so just totally arbitrary decisions about what I do or not do, how I want you to present or not present, anything that just is intended more to keep you off your toes rather than keep you on your toes. The hidden curriculum, where faculty behave in one way that's counter to the way we've educated, particularly when there is mistreatment or distreatment of one set of individuals, for example, residents, students, nurses, in the setting of very appropriate treatment of patients. So that sort of disconnect is very jarring and actually makes you wonder about the integrity of the individual. Shortcuts in clinical care, documenting things that you didn't do or weren't observed to do. And then lots of character issues associated with these issues of integrity, discernment, fidelity, humility. So assessment without observation. making a judgment without an assessment, so giving a grade without actually having sort of watched the individual do something that would allow you to judge their ability. Exploitation or mistreatment, and lack of acceptance of responsibilities inherent in your role. And from a caring perspective, probably the number one thing that we get concerns about, which relates to the community of practice and being invited into a community of practice, is indifference or exclusionary behaviors in the clinical environment. So basically inviting someone in and then rejecting them as not being a valid member of the team interferes with the development of trust and trustworthiness. So at the beginning, I asked you to consider whether or not trust and trustworthiness could be used as a unifying construct in learner and faculty development. And I will be the first to say this is incredibly daunting. I like to say it's daunting because it's hard because this is so soft, right? We much prefer things that you can put numbers on. You know, their level of prudence is a 6 rather than a 4. And that just doesn't seem to work. Whereas you can sort of say they got the IV started with 2 sticks rather than 4 sticks, right? I mean, there are lots of things that we try and quantify because we have the illusion that it's subjective. But in fact, the studied decisions of faculty around entrustment can be really powerful. And we need to be willing to embrace the emotional aspects, the language that comes from ethics and philosophy, to raise questions about how best to teach and assess this. The other thing that I think really interferes with us, our willingness to accept this as something important for us to focus on in medical education, is that most of us, when we think about trust in long-term relationships that we have as individuals. And that's our personal experience, and we know today those long-term relationships are not prevalent in the environments in which we work. So I think it's important to introduce this concept of swift trust and to contrast affective with cognitive trust, which is the frame that's used in the literature quite extensively. So affective trust arises from familiarity, shared experience, that reciprocal disclosure we discussed, fulfilled promises, and non-exploitation. It actually happens over time and can be really a spectacular outcome of a long-term relationship. But there's a concept of cognitive trust, which is increasingly evident in the organizational literature, which is trust that occurs swiftly. Swift trust is a form of cognitive trust, based on known expertise in the environment, shared goals, and a willingness to actually engage, take an informed leap of faith, and then reinforce your decision or change your decision through frequent interaction, social connections, and engagement. And so this is actually described very nicely in the relational coordination literature by Jody Hoffner-Gattel, who showed that teams that have high relational coordination, and relational coordination is the same as swift trust. If you read her literature, you can sort of interchange those words, have better outcomes for patients. I mean, for example, they have better outcomes in terms of lower readmission rates for patients after hip surgery. And what's interesting about swift trust is it's not dependent on my understanding who you are as an individual. It's about understanding who you are as a role that you're taking. So that's why it's very relevant in the healthcare environments. People develop swift trust because they know the nurses are good and we can trust nurses. They know doctors are generally good and we can trust them. It's not uninformed, and it's not unimpeachable. So if you do something as a physician to actually reject someone's trust, that actually may damage the organization's future trust. Oh, I just want to say that one validation point is in Howard's article that I just walked you through in medical education with that nice diagram. What she identified is faculty make decisions to trust very quickly, within the first day or so of interacting with residents. So there is some face validity that swift trust does operate in our environments. So what can faculty do to demonstrate trustworthiness? As we alluded to earlier, there's things you shouldn't do. You shouldn't exploit. You shouldn't treat indifferently. You shouldn't reject. But I think it's important that we begin to talk about the critical aspects of trust and trustworthiness and connect those to our competency decisions. And even thinking about that language, I can trust you to do this because I see the following elements in you. And trustworthiness is the most important thing that we can focus in on. Trust is really the cornerstone of this relationship we have with our patients. Secondly, you cannot decide on trustworthiness just by observing. Some of our focus in faculty development has really been, just get in the same room with a student or the resident, directly observe them doing the task that they've been assigned, and then describe how they did it and whether that was good or bad. But that's actually just the start. Direct observation isn't just playing the video of the encounter as you saw it or as you witnessed to it occur. You actually have to use, in order to assess character and character, more exploratory questions. You have to ask questions that might get at that person's understanding. What would you have done if I hadn't been here and when you ran into trouble? How might you deal with it if the patient was too uncomfortable for you to continue? What would have happened if you had had a major complication? How would you have handled that? Those are the types of questions that can tell you whether someone not only has competence in what you just saw them do, but actually has the character to be trusted because they demonstrate the appropriate amount of prudence and temperaments and beneficence. And so thinking a little bit about what type of questions might we teach people to use to better get at some of these trustworthiness characteristics and explain to our learners why those questions are relevant for elements of trustworthiness. And recognize and demonstrate behaviors that are proxies for trustworthiness. These come from both the relational coordination literature and also from the Gallup poll literature, because Gallup has some of those questions which are all about trust. Do I have a best friend at work? Is 100% about trust and your environment. I know everyone hates that question. But in fact, it's really about, do you have someone at work who you trust to help you, who you trust to tell you when you're doing something wrong. So respect, teamwork, courteousness. This comes from Tom Lee's work. Careful listening and showing concern. We talk a lot about the ratio of positive feedback to corrective feedback, but I would actually like us to think a little bit about how many times do we show concern, and what's the ratio of concerning comments or comments that show concern, not concerning comments, to corrective comments, and we should think a little bit about. But also our communication issues. Frequent, timely, accurate, and problem solving should be the markers for the best type of feedback that we give our individuals. That it can't be waited until the end of the rotation and sort of said, 3 weeks ago I saw you do something wrong. It's got to happen every single day, little bits of information that help people move forward. And that all sort of sums up to the role as faculty as coach rather than judge. Coach much more often than judging. And that means not every encounter that you have leads to a summative decision. Not every observation you make should lead to a decision that this person is a 4 or a 3 or a 9 or a 10. It's just they are who they are today, and tomorrow I want them to be this person. Our role as educational leaders, and those of you who develop the programs, actually can set faculty up for success and set learners up to be more trusting of their faculty. Part of it is how we run our programs, trustworthiness and administration. That same elements that actually help individuals help organizations. So reciprocal disclosure, promise fulfillment. Don't make promises you can't keep, but when you make a promise, keep it. That actually instills more trust in the organization. Prioritize faculty roles in building trust and let committees do the heavy lifting of high-stakes decisions. So it's better for the faculty to function as a coach and then describe who this person is and what they can do, and allow someone else to make those summative decisions about pass, not pass, honors, not pass. And again, focusing on narratives rather than numbers. There's a book called Outrageous Misconduct, which has issues of an analysis of distrustment around the medical profession and research. And it has this wonderful phrase in it that statistics are stories with the tears wiped away. And I think about that a lot when we are talking about describing people in terms of where they are on a Likert scale. Those numbers are people with the tears wiped away, stories with the tears wiped away. And I think we'd be better off if actually we stuck with the stories for a lot longer than we jumped quickly to the numbers. And then I think the other thing is we have to think about assessing and rewarding faculty for behaviors that foster trustworthiness. We don't talk about this. It feels a little bit too esoteric, but it's actually, I think, more concrete and actionable than professionalism. And in fact, I think trustworthiness is really kind of the core to professionalism. And thinking a little bit, and this would be something we could debate, could you take more action to be trustworthy than the more abstract concept of professionalism? The last thing I'll make a comment on is the importance of trust being a bi-directional street. I have to trust you for you to trust me. Reciprocal disclosures of vulnerability, reciprocal episodes of fulfilled promises. this begins to look like a compact between us and our learners. And one of the things that has been done in some of the organizations around trust is to develop trusting relationships. They've been willing to say, let's make a compact between the two groups that are supposed to trust one another, and let's actually let each group write the other's commitment to them. So what would it look like if the learners wrote the faculty commitment compact to them and the faculty wrote the learners compact and then switched and saw what they looked like? But these are things I think learners would ask of us as faculty. Know where I am and where I need to go. Invite me to join your team and do important work and to try new things. Show me how you think through things and how you manage difficult circumstances. Watch me, analyze my work, and help me understand my strengths and weaknesses. Challenge me, tell me how to improve, and help me make good decisions. And I, in turn, will demonstrate the character and caring in all interactions. So we should think a little bit about whether a compact between learners and faculty to support mutual trustworthiness would be an important activity for us as an institution and as a profession. So I'm going to stop there and summarize again with the conclusions I started with. Trust is needed in any relationship where someone in that relationship has something important that can be lost. And while we think about trust a lot in our doctor-patient relationships, I want you to continue to do that, but also sort of expand your thinking about trust and trustworthiness to your relationships that you as faculty have with your learners and all of the environments in which you interact with. And hoping that we as a profession can take this on as a critical element in how we need to educate trustworthy professionals and use the literature on trust that we can actually mine to actually identify new insights into this work. So I'll stop there and invite any questions or comments. Questions, comments, thoughts, arguments? Yes. Mm-hmm. Great. Mm-hmm. Yeah. So the question was, or the observation was, that another barrier to the establishment of trust is the time and productivity expectations for faculty that create very difficult working circumstances for the faculty. And so, what can we do for that? So, it's a super important question, and in fact. Many of these things that develop trusting relationships do take time, right? Even it doesn't have to take a long-term relationship, but you have to have a few minutes a day. And in fact, some of the literature suggests that those first 2 days of a new team are the most important, and if you can have a ton of interactions in days 1 and 2, you actually can develop enough trust to ride you through a longer period of time. And so I think these are conversations that we need to have with our administrators. There's trust between administrators and physicians as well. And in fact, that argument I made about having the administrators, having one group write the compact for the other group, came from an organization where the physician group and the administrators were at odds. And one of the ways they moved forward was to create a compact that basically said, we need to, in order to do our jobs, accomplish something, and we want you to agree, commit to this, and we'll commit to this in exchange. And so one of the things I like about the concept of trust and trustworthiness is it's a high enough concept that everyone has to agree with it, right? No administrator is going to say that that's unimportant. And so if we can get people to raise up to that level and then have a conversation here and then say, okay, let's talk about those practical applications of this, I think it's critically important. We need to make money. we need to see patients on time. They have busy lives. They don't want to be sitting here forever. And we also need to develop the types of relationships that are going to allow us to be more effective and efficient in the long run. So it's a big organizational problem. There's no easy answer, but I do think engaging our administrators in the same conversation about erosion of trust as a consequence of time and work productivity issues, I think would be where I would begin. And I would anticipate it would be a heavy lift. Yes? Yeah, go ahead. Hi. Yeah, I think that's an excellent question, and I think gradient of power does. I think it has a paradoxical action. I mean, so there's sort of two ends of the spectrum. I mean, we've all had patients who like, oh, this is the doctor. They know everything, and they instantly trust, right? I mean, that's we don't see that as much anymore, and I think the internet has a lot to do this. If we remember back in the day of Flexner, the only way you could get medical information was through the physician. And so older patients, and in fact this is very true in the literature, older patients are much more likely to trust than younger patients. And part of it is because while the power hierarchy might still exist, the information hierarchy is much narrower, right? But I think that there are other examples. So for example, minority learners in a majority environment, the power hierarchy is extraordinary. And there's good reason for people, because of historical issues related to discrimination and racism and in many of the other aspects of society as well as healthcare, to create that distrust. So sometimes there's a power hierarchy that creates it, and then there's some actual distrust that actually broadens that relationship. So the most important thing is some of those things I talked about. Listen carefully to what their goals are. Show concern and make concerning comments. You know, I really care about what your needs are. I really care about you getting better. I care about you feeling good about the work that we're doing. You can trust me to help you with that. Even using that language, I want to trust you. I want you to trust me so that I can help you move forward. And then I do think the Swift Trust literature, Swift Trust, it's super hard to say that, Swift Trust literature is helpful because it does talk about how people will cement their initial instinct to trust very quickly within the first couple days of work. And so I keep thinking there's something that we should be doing differently on day 1 and 2 of a rotation than that we're doing later on in the rotation. And thinking about those as being pivotal days where trust has to be developed or can be lost, I think might change the way we interact. I personally, as having read this literature relatively recently, I personally have been thinking about how I will face my next ward rounds and sort of thinking about that day 1. I've spent a lot of time there, and it will all be trying to sort of look at exhibiting behaviors that I think are trustworthy. This is a really great question. And I think paying attention to who's more vulnerable is important. Eric and then Howard. Yeah, so rapidly changing organizations, the barrier to trust there is that it may be hard to fulfill the promises that we made, right? I mean, so because if the situation is changing minute to minute or day to day or, you know, week to week even, it may become apparent that what we promised should not have been promised. And so I think the first thing you have to do in a rapidly changing environment is kind of establish expectations. It's really less about the outcome and more whether or not your intent to work with me and your motivations in making decisions were positive. And so rather than promising the world and delivering, Lake Street, you actually have to sort of think about what are the goals that are going to bind us together in this relationship? How are we going to manage expectations? Transparency is another big thing that people talk a lot about because it shows a level of openness and willingness to be held accountable and to be critically analyzed. So I think many of the things about leadership that you all are very familiar with, that's where I think leadership is a nice character model. Caution about overpromising, engagement of the individuals, mutual work and mutual disclosures. I'm not certain. I can't promise. I'm concerned about this, as opposed to I have great confidence everything will work out. I think all of those things are elements. And that it's similar to what you had asked, though. It's a very hard lift. And I think it's a good thing to think about as a leader. Am I trustworthy? Am I acting in a way that will allow me to build or sustain trust? I think would be a really interesting way to be thinking about that going forward. And you have a lot going on now. Oh, I will talk to Howard after. Sorry, Howard. Yes. All right. Thank you all.